My name is Michelle Leach, and I'm a professor in radiation therapy here in our department, and I'm leading this webinar series. So we're delighted to have you all join us today, whether it's live or you're listening back to our recording. We understand that clinical issues crop up and that people have to step in and tend to those duties first of all. So wherever you are, you're most welcome. I guess first of all, the purpose of the webinar series overall is threefold, really. First of all, it's to highlight some contemporary issues in radiation oncology practice for our colleagues. Second is to provide some continuous professional development opportunities for our colleagues in radiation therapy, radiation or clinical oncology and medical physics. And finally, it's also to provide, I suppose, a spotlight on radiation oncology as a specialty, and radiation therapy as a treatment for both for patients and the public. And you'll see as the year goes on that we will be having some events that are quite targeted towards patients and the public. So I hope you'll be able to join us for those as well. Just a few housekeeping issues, just to say that the recording will be available on our website in the coming weeks, and the URL for that has been sent to you via email this morning. Just to note then, because the webinar is recorded and available on the website, copies of slides will not be made available. During the presentation today, there will be some interactivity, so I'd ask that you use the chat function when the presenter asks you a question, and you can put your answer in there and we'll go through it from there. If you have any specific questions and comments, which we hope you will have, please use the quick Q&A function. At the end, if you have a burning issue that you want to raise verbally, that's no issue. Please just use the raise your hand function and we'll give you control of the microphone. But just please be aware, if you take that option, you will be recorded. So just that you're aware of that and that you're happy enough for that to happen. So I think that is all my housekeeping issues on my note here. So I'm delighted then to start and to introduce today's speaker, who is my colleague, Dr. Anita O'Donovan. And Anita is a radiation therapist, and she's an assistant professor here in the discipline of radiation therapy at Trinity College in Dublin. And prior to joining Trinity College as an assistant professor, Anita worked as a radiation therapist in St. Luke's Radiation Oncology Network in Dublin and in Cork University Hospital in both clinical and research positions. Anita's teaching here at the university is predominantly in the areas of quality and patient safety, as well as medical legal practice, aspects of practice, and that's at both undergraduate and postgraduate level. She is a member of the ESTRO Radiation Oncology Safety and Quality Committee, known as ROSC for short, and was appointed to the AAPM TG 288 as the ESTRO ROSC representative to develop consensus guidelines for the narrative section of incident report forms. And that's what she is going to discuss today. So Anita, I see you've already shared your screen, so I'm going to mute myself and hand over to you at this stage. Thank you.
Great. Thank you, Michelle. Thanks for the introduction and for organising everything for today. So as Michelle mentioned, I was appointed via ESTRO ROSC to the AAPM TG 288 group. And I suppose the purpose of the group, as Michelle mentioned, was to develop guidance on the narrative section for incident reporting and learning systems. And I'm joined online today by the chair of that group. So Professor Bruce Tomlinson is also online, and I'm sure may want to contribute during the webinar as well. So feel free to interject at relevant points, Bruce. So what I was going to cover today was, first of all, give you some background on TG 288. So what was the purpose, the scope, and kind of background information. What is a narrative? I'm sure you all know what it is, but why it's important for radiation therapy, particularly for incident reporting and learning for patient safety. Why do we need guidelines? Some would say a narrative is intended to be free form. So why was this group convened, I suppose, and what is the purpose of guidelines in the first place, or what do we have already? So I'm going to present just the final consensus from the TG 288 group on what should be included in the narrative, and just mention some examples, I suppose, to show the application of that in practice. I've included two examples that we discussed and worked on as a group. So first of all, the purpose and the scope of the group. So for, as I mentioned, The group has been chaired by Professor Bruce Tomlinson, and it was convened to address the free text incident reporting narratives that are included in incident reporting and learning systems. So this applies to both internal reporting and learning systems, and also anywhere where you might report externally. So that might include national and international databases. So nationally, maybe for statutory or mandatory purposes, for example. And then we have some international databases, mainly voluntary databases like Saffron and Roses. So it applies to anywhere, I suppose, that we are required to fill out a narrative section. And I suppose, aim of the group was to assist in writing those narratives in an efficient manner to ensure that they have enough clarity, I suppose, to provide information that can assist learning. So the important thing is learning from incident reports, and the initial narrative, I suppose, being the first point in developing our kind of overall understanding of an event. And it applies to both incidents and near misses. So any event that's reported as part of an incident reporting and learning system. So what was considered out of scope for the group? Before anyone asks any questions about this, we didn't go into any detail on analysis, on root cause analysis. And in relation to our, I suppose, scope, we also didn't discuss systems design at any great length, because that's already been covered by another AAPM group, which I can refer you to, which is TG100, and already been published. So just to talk briefly about the composition of the group and to show who inputted into the final guidelines. First of all, it was multidisciplinary. So we had representation from medical physics, radiation therapists and radiation oncologists, and again, very ably chaired by Professor Tomlinson, who had an arduous task in getting everybody to, I suppose, convene towards the final consensus document. We had various stakeholders from, for example, international organizations like the International Atomic Energy Agency, Saffron, Voluntary Reporting and Learning System, and various other kind of stakeholders and representatives and experts in the field. And as I mentioned, I was appointed as a representative of ROSC to input from ESTRO perspective. So our target audience for the guidelines is anyone completing a narrative section of an incident report in radiation therapy. It's also intended, and that's why we had input from those stakeholders, for anyone analysing those reports and importantly seeking to learn from radiotherapy events, anyone who's designing or maintaining an incident reporting and learning system. And it applies to both internal and external incident reporting and learning systems. And I suppose it's really important to say that the final guidelines, while they recommend certain headings and certain aspects, may not always apply to every incident. So, and it's not intended to be a restrictive kind of checklist of things that need to be included. It's just to give guidance. And I suppose recognizing the fact that we currently lack guidance, as I'll highlight in the presentation. So some of the terms and definitions that we've used are very much from an American perspective. So the AHRQ, the Agency for Healthcare Research and Quality in the States, we reference their glossary in terms of the terminology used in the guidelines, and also a seminal paper from Eric Ford and colleagues on consensus recommendations for incident learning database structures in radiation oncology. And it applies, as I mentioned before, to both incidents and near misses. So to all of the definitions shown here on the screen. And really important, I suppose, to highlight that while our main focus was that initial report, so that report that you would first file to an incident reporting and learning system, for example, as a radiation therapist on the treatment unit, we refer to that as the initial report. It could also serve to guide, I suppose, subsequent reports. I suppose recognizing that in some reporting and learning systems, the initial report is updated, and we see that with some examples, for example, from Royals, with additional details that emerge kind of after a causal analysis. But generally speaking, our main focus was that initial report. So just to highlight that. And we also made a distinction, again, while we're not focusing on causal analysis, between, and the HRQ glossary distinguishes between that kind of maybe lower level causal analysis versus a more detailed root cause analysis. So when we refer to that terminology, root cause analysis is more onerous in terms of what's required in your department or institution, and it usually refers to more kind of higher level incidents. So that's just the terminology out of the way. And I suppose just to highlight the main reason why we report incidents is to learn from experience, and the narrative is, I suppose, the first step in that learning process. And we all know that reporting culture is really important in any department. So these guidelines, I suppose, we're trying to bear in mind the way that we report, that sometimes when we're working clinically, we often don't have enough time. So they try to bear that in mind, and they recognize that when we're working clinically, time constraints are a very real consideration as well. So reporting incidents and near misses, obviously equally important, because near misses are far more numerous in terms of their occurrence and their important learning opportunities. Okay, so what is a narrative, first of all? So the definition that we use is an account of connected events. It's the description of what happened, or the story. So again, some would say, and I suppose we had a lot of discussion about this in the group initially, that it's important not to be too restrictive, because obviously the story can differ from one incident to another. But looking at, I suppose, existing guidelines and discussing amongst the multidisciplinary group, we decided that there were some essential elements that we should include. And these include, first of all, clarity. So it should be clear exactly what happened. There should be sufficient detail, I suppose, to understand what happened, while being brief at the same time, recognizing that, again, we don't often have a lot of time to complete the incident reports in the first place. So it's no tall order to be clear, detailed enough, but brief at the same time. So writing succinctly, really important. Really important that we have a chronology of events, so that it's relatively organized, and that kind of feeds into clarity in trying to understand what exactly happened. It should allow, or reference, while not being a root cause analysis, but reference the safety barriers that were effective or ineffective. And if there's any kind of immediate impact on the patient, that should be included as well. It may not always be relevant, of course. And it should allow for a selection of appropriate corrective action. So it should kind of allude to possible contributing factors. And they're not just at the individual level, but some at the kind of systems level as well. So they were the important components. And I suppose, again, highlighting the incident report form is mainly concerned with, active failures, I suppose, leading to the incident. It should identify some of the safety barriers, as I mentioned, that failed. So those layers of Swiss cheese, in accordance with James Reason's model of organizational accidents, and again allude to some of these, unsafe acts in the organization in relation to the safety culture and practices within the institution. But it wouldn't necessarily include detailed analysis of these latent conditions, but again, have enough detail to promote a discussion about the possible contributing factors. So why is it important? So most incident reporting and learning systems have restricted options in terms of the choices, and that's important, obviously, for the taxonomy in internal reporting systems or national or international systems, and it's important for classification and for analysis afterwards. However, the narrative is really the only opportunity for a first-hand account of the incident to be reported. It doesn't restrict the reporter, and again, these guidelines are not intended to restrict to any particular format, but just to suggest content that's important. It should convey a detailed understanding of the incident in order to initiate that more important causal analysis, or indeed a more detailed root cause analysis as appropriate to the level of the incident. They are designed to be free form and obviously textual. And again, we are suggesting headings that you may or may not include the headings, but we have our examples are very much in a free text format as well. And there are some challenges, of course, with the freedom that we've traditionally had in the narrative section of incident reporting and learning systems, which is, again, another reason why we convened this task group. So I just wanted to pause here and maybe refer to the panel that's present here today, just any challenges that you face in your everyday practice, whatever setting you come from. I know we have representatives nationally and also from international kind of organizations that work in different settings, but what are the key challenges that you face in your everyday practice when it comes to the specific narrative section when writing, or perhaps in your role it's reviewing the narratives? So just take a minute, if you can put your comments in the chat, please. Or again, if you prefer to use the microphone, as Michelle mentioned, you can raise your hand.
Probably people are a bit. Oh, hang on. It's me. I should have known. It says chat is disabled. Okay, so sorry if you want to raise your hand. I should have known it was me. I was thinking there was a few people who would like to say something. So
I was thinking everybody's being very shy.
so if you'd like to raise your hand, please do, and I'll give you the microphone. If not, I was just thinking, oh, hang on, we have someone there. Bruce, let me see. Go ahead, please.
Yeah. Hi. This has been very clear and very nice so far. The biggest challenge that we have with our reporting system is that the reports just give the impression of the person that's writing the report in a matter of a sentence or two, without details that they don't realize have any bearing on the analysis. And this is very, very common, which is one of the reasons that we're all right here.
Right. Thank you, Bruce. And a special mention for Bruce joining today, because it's 6 a.m. in Wisconsin, I think, at the moment. So he made a special effort to join today. So thank you. Okay, so I don't know, some people may not have their microphones enabled. So I can move on. If it's easier, if nobody has anything that they'd like to add. Sorry, Liz has raised her hand there.
Go ahead, Liz. You should have.
Yeah, hopefully, can you hear me okay?
Yes.
Brilliant. Yeah, no, I just wanted to jump off what Bruce was saying there, that I agree. I mean, for me previously, what's been difficult is that either people have provided too much narrative, and then it makes it difficult to kind of weed out what is important, or, as Bruce said as well, sometimes people don't include details that actually are quite critical.
Exactly. So we have some people who are very good creative writers, and I suppose it's a balance between being detailed enough while not being a work of fiction at the same time. And I suppose the level of effort in terms of analysing those types of narratives for the people analysing the final reports, it's often difficult to weed out the important information, as you said. Sarah?
Sorry, just let me find Sarah on my list and give her speaking rights. Go ahead, Sarah, that should be working.
Yeah, that's perfect. No, it's just a quick thing that sometimes I found in different centres, our reporting forms were very kind of not tick box, but very short, and you weren't really encouraged to write narratives. And it was more that you kind of just stated facts. And I suppose maybe we're a little bit out of practice as well in that it's not something that we would have been used to doing. So I think that would be a bit of a challenge writing them too.
Mm-hmm.
Yeah, absolutely. And again, I think that's to keep the analysis simpler sometimes. You know, a lot of incident reporting and learning systems might put character limits, for example. And again, you know, that's not always helpful, or where you don't have the option of a narrative section. It's not very informative. So I suppose just some common challenges, and again, the reasons for TG288 is that there is marked heterogeneity in content and quality. We do have the very long-winded narratives that Liz mentioned, and then on the other side of the coin, like Sarah mentioned, we may not have any opportunity to offer a detailed narrative. So there is a lot of heterogeneity there. Lacking important information, as Bruce mentioned, or a lack of clarity, or even inaccurate. And they are subject to reporter bias. Again, the initial report, whoever completes that can be very biased in terms of their perspective of what actually happened. Often lacking a systems perspective, and we discussed that within the group. And while we didn't go into detail on that, we did mention that that might be down to the fact that a lot of the education on quality and patient safety lacks a systems perspective, and systems engineering and understanding kind of the contribution of that to incidents and near misses is often lacking, and that can be problematic in terms of the final report and analysis. It can be unprofessional at times, so maybe referencing or assigning blame to colleagues. It can be defensive or emotional, understandably, and assigning blame to self or others, more often to self, I think, in a lot of these instances. In terms of the organisation, it can be confused or modelled, particularly on the chronology of what actually happened. Or it can attempt to be analytical. And of course, that's not the purpose of the initial narrative. While it is important to attempt to point at kind of relevant possible causal factors, a detailed analysis or kind of a causal analysis isn't appropriate at this stage. And sometimes it's too short, sometimes it's too long. Hypotheses might be presented as fact when they're not known to be actual facts related to the incident. Time constraints, we know that working as a radiation therapist or working as a medical physicist or a radiation oncologist, all subject to time constraints. So very often we don't have time maybe for very long or detailed reports. That's why we need to be more efficient in terms of what we initially report as part of the narrative. And particularly for external reporting and learning systems, sometimes acronyms or terms are used that aren't understood outside of that institution. So it's important to avoid doing that so that it can be understood externally. So this is just an example taken from Saffron. So some of their examples in terms of the heterogeneity that I mentioned. So we have very much the first one here, lacking in detail. So these are narratives that were entered into Saffron. This one a bit more detail, and then this last one here a bit more detail again. So we have again a lot of heterogeneity. So again, I don't know if anyone has specific guidelines on the narrative section of their incident report, if they'd like to maybe use the microphone. I would guess that most of you would say no to this, but if anyone has specific guidelines, it'd be very interesting to hear from you either now or I suppose towards the end of the presentation when we have a discussion about the kind of overall guidelines, just to think about that. But just to look at existing guidelines, and I suppose at a national level, internally, I know from working clinically, and some of you have mentioned it as well, there haven't been specific guidelines in any of the institutions I've worked in. This is taken from HICWA, which is our National Statutory Reporting and Learning System. And I suppose when highlighting some of the existing guidelines, we can take snippets from some of these, but they don't have, I suppose, the overall picture of what we think should be included in a narrative. So again, this is for statutory reporting, so incidents above a certain threshold. There are some guidelines on what should be included here. So the information should be factual, objective, and accurate. And again, that's used for kind of subsequent analysis. And there should be some reference to immediate actions taken to prevent recurrence. And again, that's one of our recommendations as well. But in terms of other guidelines, and as part of the preparation for this presentation, I just looked up a few of the more prominent reporting and learning systems nationally and internationally, and mostly internationally. So this is from the US perspective. So the Center for Assessment of Radiological Sciences is a client reporting and analyzing reporting and learning system in the US, which means that institutions send their reports externally for analysis. So they have some guidance. They highlight the importance of chronology. Again, that's something that fed into our final recommendations, and also some contributing factors, being clear and organized, and it doesn't need to be long, but being as brief as consistent with explaining what happened. This is from the Canadian Reporting and Learning System. So this is from one of my Ross colleagues. Brian kindly provided this information. So in terms of what should be included, the description should adequately summarize the incident, the sequence of events. And again, it can be used obviously afterwards for investigation. And if you look at the bottom here, a detailed factual description of what happened during the radiation treatment incident. Text may include relevant details such as equipment involved, provider roles involved, patient condition, circumstances leading up to the incident, sequence of events, immediate outcome, patient history, physical characteristics, and test results. So this is one of the more detailed guidances that exist. And I suppose, again, a lot of these were included in our final recommendations. Royals, which is a system from AAPM and Astro for, again, external reporting and learning, and the purpose being, I suppose, for community learning. You can submit your report with or without analysis, and you can highlight reports for community learning that kind of are presented for educational reasons, and their website is a very good resource for that. But they don't have any specific guidelines that I'm aware of in terms of the narrative. And likewise for international voluntary reporting and learning systems like Saffron from the IEA, they just say describe the incident in detail. And we already saw 3 examples where people have interpreted that in different ways and given varying levels of detail. Also the Roses from Astro likewise gives, I suppose, relative freedom to institutions for in terms of the narrative that they might include. Okay, so I suppose coming on to the purpose of today is to present our consensus on what we feel should be included in relation to narrative components. And I suppose the first recommendation that we've included is that incident reporting and learning systems should have a short synopsis at the very beginning. So 1 to 2 sentences of free text that, preceding the narrative, just describing what exactly happened. So we can get a snapshot at the kind of initial stages as to what the main cause of the incident was. So these are just some examples here. So again, 1 to 2 sentences presenting a clear summary of the incident or near miss. So sorry, this is a busy slide, but just to highlight this, these are our final recommendations in terms of what should be included. And I know I'll probably hear a collective moan in terms of how would we have the time to include all of this information when we're working clinically. So again, it's just to highlight not all of these categories would be applicable to a particular incident, and I'm going to see how we applied those in some examples shortly. And there are other examples, kind of worked examples in the final publication, which is due to be published shortly. And I'm going to show you, via the examples. There's one particularly long example and one shorter one. So just to show that it can actually be done in a relatively short narrative. And I suppose to bear in mind, when we were developing these guidelines, we had input from a lot of people and a lot of disciplines, whereas when you're completing your narrative, it's very much from your own perspective. So it's unlikely to be as long as the first example in particular. But just to talk through the different categories, I suppose the first one is fairly self-explanatory. What actually happened? So what happened, what the exact steps were, anyone who was involved, and I suppose paying particular attention to deviations in protocols or procedures, or maybe where a clinical decision had to be made, offering information that there was no guidance in that particular instance. And anything that you order or that you include, I suppose, should have significance. So if you're saying something was done or not done, and this might be particularly important in external reporting, it might be well known in your institution why that is important when you're reporting externally. I suppose what we said is don't omit the significance of a single step. Again, it may be fairly self-explanatory to your colleagues, but if you were sending it externally for analysis, it may not necessarily be so comprehensible. So anything in relation to how the patient was managed during the incident or near miss as well. The second section here, so relevant circumstances and actions leading up to the incident. And again, while we're not looking for a causal or root cause analysis, it should point to some of those, again, systems failings that may have contributed to the incident. And an example being, working over extended hours, personal stress, circumstances during a pandemic may have been relevant in the past number of years. Physician-induced time pressure, interruptions, downtime, delays, all of those factors, shortages of staff might be important here. And again, while not doing a very detailed root cause analysis, just mentioning, I suppose, the kind of circumstances at the time of the incident. The third section here is in relation to safety barriers that are in place, but that maybe failed or weren't adhered to. So this again might kind of give us a better understanding of maybe the safety culture of the department, or barriers that are ineffective that need to be redesigned, basically. So what exactly prompted the discovery of the event? So was it imaging? Was it a clinical review? Was it very far down the line in terms of safety barriers, or was it one of the more immediate safety barriers that are in place as part of the institution's quality assurance? So, and again, error messages, for example, that may or may not have been taken seriously, chart checks, or any issues setting up the patient, difficulty with patient setup and kind of those initial clues maybe not being taken seriously. The fourth section, again, this may or may not be relevant, is equipment related. And we'll see in our example in a few minutes. An example of that would be the imaging system not connected to the record and verify system. And there are many other kind of equipment related factors, and they may or may not be relevant depending on the type of incident or near miss. And the fifth section is the immediate response. So if, for example, was it necessary to take the unit out of clinical usage? Was it at that kind of more serious level? Or reporting or discussing with the radiation oncologist, sending it for a dosimetry review is usually fairly standard. And maybe if there was any kind of acute impact on the patient, how that was managed at that juncture, again, may or may not be relevant. The time span we felt was important. So while it's important when you're reporting, I suppose, externally, to be aware of not identifying patients and providing identifiable material, and sometimes timeframes can, they can lead to identifying a particular patient. So by that, I suppose by timeframes, we mean, particular time of day, or coming up to holidays or out of hours, or anything that puts additional pressure, from a systems perspective is what we mean there. Or, a lunchtime, over lunchtime when the unit is short-staffed. And again, that will feed into our causal analysis. And the last one is how staff members or other individuals were affected during or immediately after the incident. So any physical or emotional impact. And I suppose that category is often not relevant because the impact, particularly on the patient, may come later because they may not be aware of the incident at this juncture, or the emotional impact on staff might come later. But for example, if staff report that they had to do something as a result of the incident or the near miss to remedy what was identified in the narrative. So they're the categories for what should be included, and we also discuss what should not be included. And again, particularly for external reports, it might be appropriate at an internal level, although internally we normally refer to patient ID. But externally, really important that we don't report any identifiable material externally, so confidential patient health information, and that's for many reasons, but also obviously bearing in mind legislation and our kind of ethical obligation to the patient as well. We also discussed the importance of not including conjecture or blame. So avoiding terms like always and never. For example, planning never send the plans on time. And again, that's just an element of, I suppose, lack of professionalism as well. And then local jargon, abbreviations, or details without specifying their significance. And that's particularly important when reporting externally. And causal analysis or root cause analysis, because that comes later, and not being too analytical or kind of hypothesizing about the main kind of root causes. So now I'm just going to present some of the examples that we included in the report. And just to say, there are some very good examples from various other agencies that are available online. And again, I'll highlight some of these resources towards the end of the presentation. But just to say that some of the examples available online, like Royals, they also include the end of the story, which isn't always known at the time of the initial report. So they're typically edited to capture those details. And again, that's for community learning, that's important. Regulatory bodies are, their purpose is obviously meeting statutory requirements, and often their reports, while very good for learning purposes, they're very much coloured by the view of the regulator. And we have to bear in mind some international voluntary reports, again, shared online and very good for learning purposes, but they're submitted by anonymous reporters. So often, I suppose, we don't have the ability to go back and clarify details. And as I mentioned, a lot of these don't have guidance, and there's a lot of heterogeneity in terms of the reports submitted. So that's another reason, I suppose, why we developed this task group, and we showed specific examples of the application of our guidelines. So this is the first example. And just to highlight, we deem this to be inadequate. This is where a patient was incorrectly treated with another patient's treatment plan. So I can give you a few minutes just to quickly read this example, and just to have a think about, in relation to the table that I've already presented, why you think it's, or you may think it's adequate, but why we think it's inadequate. So just take a few minutes to read it. Okay, so when we assess this example, and just to mention, our examples were all taken from either clinical departments, and there are 3 examples that we also included. So 3 from clinical departments and 3 from the International Atomic Energy Agency SAFRON reporting and learning system. So this is a clinical example from various participants of the task group. And just to highlight that in terms of the inadequacy, we felt there wasn't enough detail to understand what actually happened. And it did include some information on relevant circumstances and actions leading up to the incident. But again, it kind of excluded most of these other categories. So this is our amended narrative, and it is, so I've spread it over 2 slides. It is a little bit, this is one of our longer examples, and some of you would probably say you wouldn't necessarily have the time to do this on a treatment unit. And I suppose, again, just to say that we had multiple people inputting into this example, which is probably why it's a little bit on the longer side. But I also have an example that's much shorter than this, just to highlight that it can be done, I suppose, in a shorter period of time as well. So in the first section here, sorry, my slides are skipping for some reason. We have what actually happened. So in terms of the occurrence, so that's the first section. And again, in terms of those headings, they don't necessarily need to be applied in chronological order. The second section here talks about how the incident was actually, or why, sorry, the relevant circumstances leading up to the incident. So again, highlighting some of those kind of causal factors that I mentioned already. So I'll just give you maybe a minute or two to read it before I move on to highlight the rest of the section as it applies to our kind of tick box. And in our final report, we have, again, we've these examples presented as tables in terms of inadequate and adequate, and we've also taken the text to correspond to the headings that we've highlighted as being important in our narrative, in the final narrative consensus guidelines. So it's a little bit easier to follow. So the next section here just highlights again some of the safety barriers that failed, and also the equipment related failures, so the cone beam imaging not being connected to the record and verify system. And then some of the immediate responses are included. So the responsible physician, medical physicists were informed. The time frame is included, so we can see that the realization, even though the patient was treated at 9 in the morning, the incident wasn't identified until much later that afternoon when attempting to call up the other patient whose plan had been mistakenly delivered. And yeah, so the final section in terms of the, I suppose, patient or staff impact was deemed not relevant in this particular case. So that's just to highlight what we've done in the report in terms of the examples. And I just wanted to show another example which is much shorter. So this is actually the narrative that was submitted initially, and you can see clearly why it's inadequate. It's lacking most of those sections in terms of our consensus guidelines. So it is an example that's very particular to the, I suppose, US healthcare system, or maybe some more private settings internationally, but and that's recognized in the final report. But just to highlight, I suppose that the guidelines can be applied and a shorter narrative produced. So this is a near miss. It's neglect on the part of the billing office made a dosimetrist do an additional plan. In terms of what's included there, equipment related details are not applicable in this particular case. And there was some information on the immediate impact on staff members in terms of what they had to do. So the reworked examples of what we considered, again, more adequate, we have details of the occurrence here. So this is where a dosimetrist planned a treatment to deliver 15 fractions of treatment, but the patient's insurance would only cover 10. So the billing office note in the chart is supposed to give limitations on treatment from the insurance company, but did not in this particular case. So that's our second recommendations in terms of relevant circumstances leading up to the incident. The day after doing the plan, so this is our time frame, a dosimetrist happened to call the billing office about another patient, and that's how it was identified. So this is, again, it's not particularly in order, but it's how the incident was identified in the first place, and then what were the immediate responses. So the radiation oncologist rewrote the prescription with the doses needed for 10 fractions, and the, I suppose, immediate response was a different plan had to be created. So again, just showing one of our shorter examples. We have other examples in the final report, as I mentioned, but just to highlight, I suppose, how we've applied those guidelines and applied the kind of final consensus. So because this presentation, and again at the end we'll have an opportunity for questions and some discussion, but just because it was developed for CPD purposes, I suppose just to highlight some of our CPD prompts, and it's often easier to do that directly after participating in a CPD event rather than leaving it until much later. So just, again, these are our national CPD guidelines. What have you learned from completing this activity, if anything? Hopefully you've learned something. How have your skills and knowledge improved? How might you integrate this into your current practice? And how has the learning made a difference to your capability and performance in your current role? And just to highlight from a CPD perspective, if you did want to kind of broaden your CPD in this topic, there are lots of excellent resources, some older like the Towards Safer Radiotherapy resource, and some newer guidance like the World Health Organization report and guidance, I suppose, talk about incident reporting more generally. And this textbook, which is open source on patient safety and clinical risk management more generally. And also to highlight from the community at large, so Royals, again, an excellent resource in terms of publishing case studies, and they have regular updates, particularly important for newer technology where they highlight safety concerns, and they have very detailed analysis of kind of certain events that are really good for learning purposes. So their website is another excellent resource. Roses, again, from our own ESTRO organization, we have developed an educational platform as well as an incident reporting and learning system. So the educational platform has a lot of free to view learning resources on topics related to incident reporting and learning and safety. And also from a Canadian perspective, they have a really good incident investigation course. So talking about not particularly narratives, but more the kind of root cause analysis. And I suppose from a UK perspective, it's also important to highlight some of the best data that we have in relation to how safe radiotherapy is, comes from, this is a national voluntary reporting and learning system from our colleagues in the UK that has 100% coverage, which is relatively unknown elsewhere in the world. So it's a very good source of information about the main sources of error in radiotherapy. I didn't find any specific guidelines on the narrative from the Health and Safety Agency, which is the body reporting these incidents, but again, a very good resource for learning. And they also have regular e-bulletins on relative safety issues in radiotherapy. So they're just to highlight resources from a CPD perspective, because that's the main thrust of today's presentation, although I recognize a lot of you online could develop your own CPD resources. So just to highlight, so before we take questions and answers, again, why a narrative section is important. So again, the first step in a reporting and learning system, it should capture exactly what happened and provide a good foundation for follow-up investigation and analysis. It should be factual rather than analytical, and there are important components that we felt should be included. And hopefully if highlighted, guidance is lacking, because while we have certain pockets of guidance from different organizations, I suppose we don't have a complete picture of what should be included. So that's why we felt the guidelines were important to develop. And these are due to be published shortly. So Bruce, you might want to give an update on that, because I know you've been doing a lot of the work back and forth with medical physics in terms of the final publication. So you might want to come in here, and then we might take some questions and comments from participants if they'd like to clarify anything. So I might just stop sharing here. And Bruce, again, you might want to give an update or a comment on any aspect of what I presented.
I would be delighted to. For those who aren't familiar with the American Association of Physicists and Medicine's task group report process, a task group is formed under a working group, which is under a subcommittee, which is under a committee, which is under a council. And the task group will write a report and send it upstream to be reviewed. And once it gets approved at that level, it goes up a level. And it keeps going up until it gets to the committee, where they review the report as it is now at that point. And they also send it to medical physics, which at the same time does a journal review. We are in the process at the very end of this, where we've gone through one round at the committee level and medical physics, and we've just finished answering the questions in the second round of reviews at that level. I don't think that there's much that they'll find with the report to comment on at this point. The committee, the task group, has been very good at writing and clarifying questions that have come up through all this review process. And we have, at the end of this week, the deadline for any comments on the very last topic that we have any discussion in the task group about, which is the title of this report, which that seems it shouldn't be controversial, but it was. So we're looking forward to having the report accepted by the committee and the journal within the next couple of weeks. So it's very close to being published. And what you have just heard here is the very first public discussion of the report, and it's been masterfully done by Anita. Thank you very much for tying this up in such a pretty package, and just like we want in the narratives, this has been very clear, and it's been short but covered the topic.
Thank you, Bruce. I couldn't agree more. I think it was a superb presentation. Thanks, Anita. And thank you, Bruce, for giving Anita permission to give the world premiere, can I say that, of the report here today. I'm reliably informed that Q&A is working. Sorry, my apologies on chat, showing my lack of experience on Zoom webinar technology. But Q&A is open if anyone wants to ask a question. But Anita won't be surprised to know that I already have some ready to go while people are thinking about it. I was just thinking about, I suppose, our colleagues. I'm also a radiation therapist, and I'm thinking about our colleagues, and particularly maybe radiation therapy managers, you know, who might be joining us today. I'm wondering, do you think it's a good idea or not, basically, that once this document is published and people have time to obviously, you know, absorb it in their department, would it be useful for a department to come together, review the document, and maybe, you know, have their own exemplars that they could use for their own department? Or do you think that that's kind of constraining what people can write as individuals, as narratives?
Yeah, I think, again, there are 6 examples in the final document. I only presented 2. And I suppose there is variation, as I highlighted, in terms of those different examples to different systems. So it definitely is important for, you know, and there will be differences in internal versus external reporting, and you may have terminology in your internal reporting and learning system that's appropriate that wouldn't be appropriate externally. So I think definitely that's a good idea to develop your maybe some recent examples in terms of what was received, while again not trying to blame or shame anyone, but to use those examples and to highlight maybe what information was missing that could have been more informative at that early stage, and using those examples, I suppose, to apply our guidelines in your particular setting. And there is another example I didn't present that was in the final document that we said, you know, sparked a lot of discussion, that it didn't necessarily reflect everyone's practice, but it is an actual incident from an institution. I suppose it's important to highlight that in terms of what actually happened. So yeah, I mean, the guidelines and narratives will be reported differently in different organizations, and we all have kind of specifics in our own department that we think are important. So I think that's a really good recommendation, actually, Michelle. Yeah.
Oh, good. I'm glad. I certainly learned something today then. I suppose we just have time for one more question, and I don't see any in Q&A. And maybe if I could ask you both, maybe a slightly more philosophical question to end with. I'm just thinking about projects that, you know, I run in different parts of the world, and I'm just wondering about what would your analysis be at the moment of, you know, I suppose the culture of incident and near miss reporting globally at this stage. I mean, is it very pocketed in that it's very well developed in certain areas, and how can we encourage those in other regions where maybe it's not so well developed to actually come on board and see it as a learning resource? I don't know, Bruce, if you want to maybe start with that one.
Sure. It's very idiosyncratic to location. There are many many countries in particular that are very good at this, and Nita did point out UK is certainly one. But much of the world this is not a priority. It's not something anybody thinks about, and particularly in places where they pretty much run the units 24 hours a day. They don't take the time for the learning, although they probably have a lot of events in those cases, and it might be very useful. Even in the United States, it's very particular. Some particular clinics have a lot of reports, and some never report, even those who have contracts with reporting systems.
Okay. I just see that. Thanks, Bruce. Sorry, Anita, go ahead, and then I see Evelyn has her hand raised.
Yeah, and just to highlight, some of those institutions or reports that report very low levels of incidents reported as a high level of safety, which is not is
kind of
really not,
that, isn't it?
Yeah, I mean, some would see a certain number of reports as being kind of a threshold for patient safety and safety culture. But I think I have read reports from you know, organizations that have said we've a very low level of reports from radiotherapy, and that indicates radiotherapy is very safe. I wouldn't agree with that.
A little general, isn't it? Evelyn, would you like to go ahead, please? I have you unmuted there.
Okay, thank you. Can you hear me there?
We can, yes.
Excellent presentation, really brilliant, really clear. I've just two very small comments. One is you mentioned about people maybe being unprofessional in what they write and blaming. And just to add to that, if the document is going to be used within a department for reporting internally, those documents are discoverable. So if a patient does a subject access request or a freedom of information request, the documents are discoverable. And I found that in my experience helpful to remind people to you know, maybe to take a deep breath before they write and consider what they're going to write in that description, and not to regret it later on, of course. And then the other thing is, I wondered, had you considered including open disclosure, whether documenting whether that happened at the time of the incident on the form? Certainly in the Irish context, when incidents are being reported to the State Claims Agency, there is a selection on the end of the form to document whether open disclosure happened at the time of the incident or not. That's it. Thank you. Well done. Brilliant presentation.
Thanks, Evelyn.
Great points, Evelyn. I'd agree with you in terms of the professionalism aspect. So we have a category for you know, how the patient was dealt with, but I suppose we were bearing in mind that at that initial reporting level, we may not have enough information to say what should be disclosed or not. And recognizing most reporting and learning systems have an additional tick box for kind of those aspects, you know, particularly you know, national legislation in terms of open disclosure. So it's not something that I suppose is always appropriate at that initial reporting stage. Bruce, you might want to add to that.
That's absolutely the case, that most of the reporting systems that I'm aware of have that in a separate section from the narrative. And it usually is just a checkbox. And at that point, the details shouldn't be in the report. That has to do with patient confidentiality. Once you say, yeah, the report has been given to the patient.
Yeah, and I suppose it needs to be discussed at a multidisciplinary level in terms of, you know, what exactly is open disclosure required? Is it actually mandated by law, for example, or by kind of national guidelines? And as well, you know, what exactly should be disclosed in what manner and by who? There's a lot of detail, I suppose, that comes with the analysis, whereas again, our focus was on the initial report.
Mm-hmm. Brilliant. Well, it's just past the hour, so I think it's probably time that we had to wrap up. I can see that there's so much discussion on this topic. We could keep going for another hour, but unfortunately that's not feasible. So once again, just to thank Anita very sincerely for an excellent presentation. Thank you, Bruce, for permitting us to have the premiere of this report, and also for joining us at that ungodly hour of the morning. So we'll let you go and get some coffee. And thanks everyone for joining today. And I suppose just to give you a sneak preview of next month's webinar, will be on February 28th. And we're looking at something completely different. And we will be inviting patients and the public to join us at that presentation. And it's about the development of consensus guidelines for the management of osteoradionecrosis. So we're moving from topic to topic, but hopefully there's something for everyone in our series. So thank you all very much for joining again, and wherever you are in the world, I hope you have a good day. Take care. Bye-bye.